Thank you for inviting us to be here today. And just before I start, I just want to make sure I have the time frame correct. So we have about till noon, I think. So what I'm hoping to do is spend, the first hour or so, essentially going over what we've done in a very, just in a presenter mode, and then I'm really hoping to spend the vast majority of the rest of the time sort of getting your input in terms of where to go from here. I should tell you, I always I feel like a bit of a fake, and a bit of a fraud, because here I am talking about 0 to 6 and measurements with 0 to 6, and really I don't clinically practice with a lot of kids under 6, unless sometimes we'll do the occasional consultation for kids who might be on the spectrum or some suspected learning issues, some behavioral issues, but really 0 to 6 isn't the my primary clinical work. Having said that, I do have a little bit of interest in early infancy. I've actually been trained. I spent time. One of the first kids I worked with when I started practicing at CHEO was in the early '90s, and I was working with a family where they had a 3.5-year-old little guy that was adopted from El Salvador, and they had a 1-year-old that was adopted from a family member, and there were some real issues there. And person I worked with who helped me, guide my own kind of work with this family was Dan Hughes, and that was before Dan was Dan. And along the way, I've always been really, interested in attachment and early parenting. And so I did the training with Dan. I did his work, and then more recently I've been working a little bit with Marlene Moretti in terms of the Connect program. And in fact, been trained, and I was actually here this past February as one of the trainers with the group learning the Connect, and back here in the fall in February again for another Connect training. So I know a little bit. It's kind of like the worst case scenario, right? Someone who knows a little bit but doesn't know, doesn't really know enough, just enough to get into trouble. And so, and even in terms of the research that I do, even though I'm a clinical psychologist, the work that I do is really health service research. And health service research is really about trying to ensure that, you're providing the right services at the right time to the right clients, the right patients, right? So it's not your typical RCT or, other type of clinical trial. It was about a year ago that we first thought about developing this tool for the under 6. And the way it started with, just to give you a bit of a history, was a call that I got from East Metro before any of this, and they were looking at building a centralized intake for Toronto, and they had heard about our tool and had heard about some of the work that we were doing, and wondering if the HEDZD tool could be used as part of its centralized intake. And I knew the work that it already started to be used at IWK in terms of their centralized intake, and we had some data that said, I think there is an opportunity there. And at the same time, the idea was, could the tool be used for kids under the age of 6? And I'm going to show you in a minute, or maybe not in a minute, in about half an hour or so, that the tool, the way it was originally designed, was actually being used as part of the centralized intake at IWK. But we just felt that it really wasn't intended for that purpose. It was really intended for kids above the age of 6 and even into some of the transitional age youth. And we wanted to really think about developing a tool for under the age of 6, using that HEDZD mnemonic. It would have to be a little bit more customized. And so over a telephone call and a whiteboard, we drew up the HEDZD mnemonic for this age group. And we've kind of thought about how to validate it and what to work on it. And again, the opportunity, I sat down for a coffee about a couple months ago or so, Chad, and I said, listen, I feel, I really want to get folks who are on the ground, who really know this area, to help me in terms of the development of the tool. I have no conflict of interest, so, to declare. And what that means is that there's no financial incentive to myself or to our group I'm not going to get a promotion if the tool gets developed and it becomes, you know, internationally recognized. And it's not about that. So it really is about that whole idea that that I've kind of guided what I've done, which is how do we really help kids get the care they need, and how do we help them connect to the services that most folks don't even recognize are out there. So I'm going to spend a little bit of time. There's three things I'm going to kind of, oh, is that just cool? Essentially three topics that I'm hoping to cover. First, I'm going to go over some basic tool development evaluation. Just a show of hands, how many folks here have done tool development and evaluation? Okay. So one psychologist. Okay, that's our bread and butter, right? We develop tools, and you know, anything you want to know, we have a self-report measure, a parent report. We have something on tool development. So I thought it'd be really important, if we're going to think about and try to tap into your expertise, to give you a little bit of background on what we mean by tool development and what actually goes into the process of evaluating it. And then I'm going to present on the HEDSED, because it really kind of shares with you the work that we've been doing for the last number of years, and potentially as a model which I'd like to sort of use, and it may or may not fit with validating the under 6-year-old version of the tool. And then hope to spend, you know, the last chunk of time in either the big group. I like doing more big group discussions versus small group, to be honest with you. I just find that, you know, big group is always a better way of doing it, and sort of in chunking into specific areas that I'd like to make sure that we touch. So I do want to thank, you know, Ashley and Paula for being here today. Paula and I have worked together since ever, and and Ashley has just joined the project, and she has a steep learning curve, and it's nice to sort of, you know, for someone like Ashley to join us, because this really is the beginning, right? So I'm trying to make sure she doesn't leave halfway through the project. Okay, so what I want at the end of the day is to be able to take home a kind of a final version. I know it's not a final version, but the idea that we're working towards a final version. Try to think of a working plan on how to evaluate the validity and reliability of the tool, map out a bit of a timeline for the plan, and also get your thoughts in terms of what are the resource needs to execute the plan. Because again, you know, these are the things that, you know, sometimes we really think we know, but we really have no idea what it actually would mean. So test development. There's a couple things that I think are musts. And so when you're looking at test development, there was a World Health Organization publication that came out about, I don't know, 50, 60 years ago on test development. And these are what we always think about as being essential in terms of any screening instruments. So the first thing, you know, that any test you develop has to be able to detect those with the disease. In other words, it should detect the thing that you think you're hoping to detect. It has to be safe and acceptable, right? You don't want to cause more pain and grief to anyone that you're using the test on. It has to be reasonable in cost so that you can actually afford to use the tool. And the last two are really important, because most people don't think about, when they're thinking about test development, in terms of, it has to be actually lead to improved health outcomes. So it's pointless to have a test that doesn't lead to health outcomes. So the really good example is like the PSA testing for men, right? And the idea that everyone went off and got screened for this test, but it really didn't necessarily lead to health outcomes. So what's the point of doing the screening? And then the last one is also really a must, that you have to have follow-up services should you have positive results. Well, it's wonderful to be able to do those sorts of things, but then if you can't offer services, then, you know, you're really left pretty short in terms of your healthcare. And you often will see that when we're looking at things like, you know, suicide screening, right? You know, if you can't, you know, that's the real controversy there, right? Is that if you go off and you do school-based suicide screening, then you identify all these kids, you know, and some of them, you know, are false positives, right? How do you still got to provide care? So what do you do, right? So in terms of test development, those are what we often consider the musts. Then there's something else that I call the Mario must, and you know, Paul was going, "Why do you call it the Mario must?" Because I don't know what else to call it. And I think, you know, any tool that you develop has to really be responsive on 3 different levels. So, and these were the things that were important to us when we were originally developing the HEDS-ED, and I think they're still relevant for whatever test. So the first thing is it has to be responsive to your specific service or hospital level. In other words, if we're developing a tool that we're going to use in the emergency department, it has to be able to help us, guide us in terms of whether admission is what we ought to be doing or whether child should be going to crisis or some other service. So it has to be able to at least help you in your core service that you're currently provided. But we also think it has to be responsive to the mental health of the needs at a community level. So in other words, that it'd be great to be able to have a tool that different core service providers and different agencies and different individuals, you know, that we would use the same language, right? And so ideally, you'd want something that helps communicate what the needs are. And a really good example is like, you know, if we're doing mental health screening in schools, that, you know, if the school psychologist or the school mental health lead is using, you know, using the same language as the folks in the emerge, as the folks in the community. And lastly, I think it's really important that that it has to be responsive to the mental health needs at a societal level. And what does that mean? Essentially means that no matter where you are, and not just in Canada or Ontario, but that you should be able to provide a pathway that any child will get the same level of care regardless of which community they're in. So whatever tool we're using here should make sense for, you know, any community. But here's the kicker, right? If you ask most physicians or clinicians or folks, you know, having to do triage tools, these are their musts, right? It has to be really brief. Can't go on and on and on. It's got to be really easy to complete. It's got to be really simple to score. It has to make clinical sense. It has to have, you know, really good psychometric properties. And at the end of the day, it still has to help guide decisions, clinical decisions in the assessment and the treatment. So they want a lot, you know, in a very small package. We could deliver a lot in a big package. We know that, but trying to get that package to, you know, the core elements that are predictive is the hard part. So I want to just touch upon validity, reliability, and clinical utility. And again, just a quick show of hands. How many folks are familiar with validity, reliability, clinical utility? Okay, great. So I'll only spend a couple minutes reviewing those. Again, mostly to ensure that when we have our discussion at the end that we're going to be using the same language, right? So just for communication's sake, I think it's nice to sort of take a minute just to go over those three main areas. So what do I mean in validity? There's many types of validity and types of validation, but there's only a few that I'm mostly, you know, concerned with. Essentially, validity tries to answer the question: does the questionnaire, the test, or the tool, or whatever it is, actually assess what you expect it to assess, right? And the simplest type of validity is something we call face validity. Sometimes we'll also use something called content validity, but face validity is basically, you know, does the item on the tool appear to measure the content area? So just by looking at it doesn't make sense, right? So, for example, the first item on the children's depression inventory is ask the child to rate how they've been feeling in the last 2 weeks as I'm sad once in a while, I'm sad many times, or I'm sad all the time. You're looking at that, and if you're looking at depression, it kind of has face validity. So the first thing is, as you're looking at this instrument, does it make sense to you? Now, it doesn't always have to make sense. So, for example, there are measures out there that when you and the classical one in psychology or mental health or psychiatry is the MMPI, right? And which is a measure of pathology based on personality traits. And the questions are, you answer yes or no to, like, I like mechanics magazines, right? As an example, like, what in the world does that have to do with, you know, my level of something else? So it doesn't. So face validity has to have face validity, but it's not the essential one. The two that I'm most concerned about, or that are captured under something called the criterion validity. So criterion validity is basically how well does your tool correlate with other criteria that one would expect. And there are two different subtypes of criterion validity that I think we need to really address when we're doing some basic validation work. So the first is called concurrent validity. And concurrent validity is you're basically measuring the construct and at the same time as you're measuring your criteria. So the really good example, an example is the measurement of children's pain. Right? So you'll look at the correlation between the child self-report pains on, for instance, a visual analog scale of pain, and at the same time you may be doing some videotaping of their behavioral responses. They're crying, they're grimacing, and the whole idea is that if you're showing, the two should correlate, right? The second is something called predictive validity. So predictive validity is essentially the measurement of the criteria, but this time it occurs at a future date. So a simple example is the measurement IQ and admissions to university. So the idea is that if I assess your IQ when you're 13 years old and you score at a certain level, that ought to be able to be predictive of whether or not your cognitive profile fits more into a college level or apprenticeship program or a university program in the future. So those are really two important types of validity. Reliability, on the other hand, assesses how consistent is your tool, right? And it's, even though I have reliability second and talked about validity first, in fact, it's the other way around. Like, if you don't have reliability, you can have the most valid tool in the world, but it's not terribly useful. If you have it's like, just think of it in terms of taking your temperature. If your thermometer doesn't, give you the, isn't reliable, you can never trust whether or not that reading is accurate or not. There are many types of reliability, but in our tool, and what we're mostly interested in, is something called inter-rater reliability. So in other words, the inter-rater reliability is really about the correlation or the relationship between the ratings from different raters. So you'll often see it in chart reviews. Someone does a chart review, they'll have a couple people look at the same chart, and they have a rating scale, and they'll see whether or not there's concordance between the ratings of the two folks or three folks in the ratings. You also see it in behavioral observation studies. You often see that, in childhood. You'll see that when you're looking at play or in social relationships, where they'll do recordings in playgrounds to see who plays with who. And you'll often find as well in terms of parent-teacher behavioral evaluations, where you have the similar measures, and everyone's trying to see whether or not you get the same profile. So we're really interested in inter-rater reliability. Utility is also really important in test development, because really this is where we're talking, where it goes from the tool psychometric property is as a theoretical or as a potential use to, does it translate now to good clinical practice? Does it lead us to do or to think about how we manage our kids in a clinical way? So in other words, utility is how accurate is your tool to identify the existence of the index or the disease. And in pediatrics or in medicine, it's interesting. If you look at tool development there, they'll always be talking about sensitivity and specificity more than you'll hear about concurrent validity or predictive validity. It's not in their minds as important. And why is that? Because sensitivity is, asks, does the tool identify whatever it is you're wanting to identify? Does it actually identify, is it actually there or not there? Right? And specificity says, is whatever it is you're interested there not there and actually not there, right? So, and that's really important, right? Because that's the idea of that you're identifying, and I'll give you an example in a minute, whatever it is that you're interested in looking at. If your tool can't measure that accurately, clinically, it doesn't, again, make much sense. The other one that you don't hear as much of is something called clinical utility from a communiometric perspective. And this is a little bit different. And essentially, in the communiometric world, we talk about, does the tool help us to plan our clinical care, in the community or within our service? So it looks at the utility of the tool in terms of subsequent actions. In other words, does the rating actually lead to the next step in care? Is it, do you have lots of folks, completing it in terms of penetration? And lastly, is the people, using the tool, does it make sense to them? Is it a useful tool in terms of supporting the individual work that they do? So just getting back to sensitivity and specificity. So if you're looking at, the really good example is, or your typical screening test when you're looking at something like suicide risk. So the question is, the sensitivity is a child, if you're screened positive for suicidal risk, are you actually suicidal, right? Versus those who screen as being suicidal and not suicidal. So those would be your screening, your sensitivity, and your specificity are your true negatives, right? The idea that someone truly is a negative and don't test negative. And that's really important, again, if you think of it, in terms of my earlier comment about, screening for suicide risk on school-based stuff. It's really controversial, right? Because, and even in primary care, it's controversial because if you have a high, false, if you have really poor sensitivity or poor specificity, then it'll lead you to making certain clinical decisions and then creating barriers to kids who may actually need the care because they actually are true positive. So it really creates a lot of challenges. So ideally, you want sensitivity that approaches 1, which is like 100%. So 100% of the time, if the person tests positive, they actually are positive, and 100% or 1 in terms of specificity that, if they test negative, that they actually are negative, and that you eliminate these false positives and false negatives. Okay. Now, basically that was your second year research methods course done at university. We just covered that material in about 10 minutes. So, but I do think that oftentimes we read these articles or we try to do the work and don't really understand what these concepts really mean, or we heard about them, but we kind of forget what they are. So I'm going to shift gears a bit and talk a bit about the HEADS-ED tool and the tool that we developed in the eMERGE for kids over the age of 6. And again, the reason why I'm going to bore you guys, even though I know none of you work in the eMERGE department, and I know that the vast majority don't work with transitional age youth or some of the older kids, but the reason why it's important to go through this is that I want to just sort of share with you the thinking that we've had over the years in terms of the development and the validation, and what I think is really important in terms of rigor, right? The idea that you just can't just sit there and think you can drop some questionnaires and simply validate it. It is very time consuming and it requires a little bit of vigor. So I want to share with you what we've done and again, the idea that some of these things might be also useful in terms of thinking in the second part on the validation of the U6. So before I start, again, lots and lots of folks have been, have provided, support and time, and I just need to take a second to acknowledge this is 30. I think, next time I present, it'll probably be about 40. Ashley's name's not on this yet. I need to acknowledge the funders, because clearly be able to do the work that we've done is really required, tremendous financial support, both from private donors as well as public agencies. And again, just I do acknowledge that there's no conflict of interest. So when we first started working on the tool development, and at that point, originally this was about 10, 12 years ago, and I was already, I wasn't working in mental health at that time. I was actually working in health, and the area of research I was most interested in was on chronic illness and on familial-based, cancer and other forms of genetic disorders, and thinking about how do we support kids and families that are exposed to these risks. And then I moved, but at the same time was practicing clinically with our mental health folks. And the one area that I thought was just an absolute disaster was how we managed the kids who came to our eMERGE department. It was, I remember in the early 90s, and I think it lasted for years, folks on there had no clue in terms of what to do and how to do it, and it was a train wreck. And I was working at CHEO, and CHEO, has a really good eMERGE department, really good dedicated, emergentologist and pediatric staff. So, and I always thought, geez, if it's bad here, what's it like elsewhere? And if you took a look at the evidence back then, There wasn't any standard of practice in terms of tools that would help emergency physicians in terms of how to triage the mental health concerns of kids, even though the professional associations, whether it was the American Academy of Pediatrics or Pediatric Emergency Medicine, all talked about we really need to develop some tools for our ED docs to be able to use. And the ED docs said, yeah, we need those tools. But only about 9% or so used any type of evidence when they were looking at assessing for screening for mental health concerns. Now, it just so happened that a couple years after I started working on this, we had that huge increase in the number of kids coming to our eMERGE. And this is this was published by Kai-Hai, and I think some of you folks may already have seen this. These two graphs are the first one is the number of ED visits from 2008 to 2014. And you can see that the number of kids coming to our eMERGE department over the years has increased by 45%. And if you look at the number of kids coming in for for typical pediatric reasons, it pretty well stayed the same over the years. And if you look at our admission rates for our kids, we had a roughly 40% increase in kids being admitted. And in fact, in pediatrics, we had about a 14% decrease in admissions. So we have this huge number of kids coming to our eMERGE, emergencies, feeling overwhelmed, ED docs really at a loss in terms of, and other staff, how to deal with. So these were 5 to 24. Okay, yeah, it's up there. And in fact, and Norman, so 80% of kids coming to the eMERGE tend to be over the age of 12, right? So there's a small percentage from 6 to 12. And the occasional, younger kids, the typical presentations, about 30% present to the eMERGE with, suicidal risk, about 30% present with anxiety, and about 30% present with behavioral issues, right? So they're either coming in handcuffed, or they're coming in with their parents saying, deal with this kid, right? And sometimes you do get the younger, you get some of the younger, age kids that are coming in for that reason, right? But I don't think, and I'll talk a bit about the U6, but not in the eMERGE. I think in primary care is where we really want to focus on the U6. But these were all tended to be the older kids. So, not for a moment do I pretend to be the expert, and I thought, what is it that other people are doing? Rather than trying to, invent our own wheel, surely there must be wheels out there already. And the best known wheel is called the HEADS. And the HEADS is a mnemonic that's widely used in U.S. medical outpatient clinics. It is slowly, I think, more and more used in Canada as well. Most physicians know the HEADS. It really is a way to organize a psychosocial interview when doing routine adolescent visits. And I'll go through it in a second, but it's taught by and promoted by a number of different professional organizations, and it's changed a little bit over time. So they've added letters, like multiple S's, right? It could be safety, sexuality, things like that. But it's a way of thinking about doing a screener without in a way that makes sense to physicians. At the same time, John Lyons was working with us at CHEO. He was he was there as the endowed chair in child and youth mental health. And John developed the CANS. I'm not sure how many folks are here familiar with the CANS or the ANSA. So essentially, and what the really beautiful thing about the CANS is that it's a communometric measure, right? Meaning that it helps you think about what services the child needs based on their actual clinical needs. And we said, is there a way of taking, the two and combining it to make, this other tool? So in other words, chocolate meets peanut butter, and we have the Reese's peanut butter cup, right? And so we developed this thing called the HEADS-ED. So there's seven areas in the mnemonic, right? H stands for home, E stands for education, employment, A stands for activities and peers, D stands for drugs and alcohol, S stands for suicidality, E stands for emotions, behaviors, and thought disturbances, and D stands for discharge and current resources. When we first developed the tool, it didn't include employment and current resources. And what happened was that we were working with the folks in primary care, and at the same time, there was a lot of discussion of the transitional age youth and the hubs, and we did a Delphi to see what are the, if we wanted to sort of refine it a little bit to make sense for the older kids, what would really have to change? And really, the only thing that ultimately changed it was including employment. And because some of these kids are working or doing part-time working or working full-time or not working. So that was a real big thing. We talked about other things in the we did a Delphi. So issues about sexuality also came up. But at the end of the day, it's always that concern between the more items you add, the less likely you're going to have uptake, right? So it's always a bit of a trade-off. And each one of those things is rated as either 0, no action needed, 1, needs action but not immediate, or there's moderate functional impairment. And lastly, a rating of 2 means that we need some immediate action, or that there's some pretty severe functional impairment. Again, originally when we developed the tool, we didn't have the moderate and severe functional impairment. That actually came out from the work at IWK. And the concern was that if you're doing an intake and you're saying, you know, this child's concerns at a level 2, but you can't provide immediate action, right? It kind of, you're stuck, right? So you're sending them to the emerge, and the emerge saying, yep, there are 2. And really what you're trying to capture is the concept that these kids have some pretty severe functional impairment. Oh, stuck. And so the paper version of the tool looks like this. It is, at our hospital, it's gone through the paper committee, as I like to call it, which is no longer a paper committee because everything's on Epic. And but it has to be, I don't know what they call certified as official kind of forms. Thank you, the forms committee. Thank you, Paula. So that is the Anglophone version of it. We have a Francophone version of it as well. This was, we have a bunch of folks in Ottawa that are bilingual that helped us with this, but we also had some folks in Montreal as Saint-Justin also have a look at it to make sure that we're slightly, that we're using as close to the same language in French. We have an electronic, this is the web-based version if you looked at it online. And so what I thought I would do is I'm gonna go to the website just to sort of walk you through only because it's a little bit easier to do it this way here. So if you went online, this is the Ottawa website, by the way. So essentially, if I started a new survey, and just to sort of, I'm only going to do it just to imagine the child is 14, and let's just say there's English, and we will make her female, and we don't suspect, we're not suspecting a spectrum or developmental disorder or disability, and we say no, and I can say that the child is in, let's put the child in Stormont-on Glasgow and Stormont-on Das in Glengarry. That's near Cornwall for folks. And so the Cornwall lead agency deals with those kids. So the first thing you'll notice is that the way it works is that you have home, 0 meaning that the home is typically supportive, or 1 would be that there's conflicts, but enough to like worry you, but not necessarily have to, that would need immediate action. 2 would be that there's chaotic or things are pretty dysfunctional. If you weren't sure what to ask, there on the paper version we list the sample questions, but you can also tab it and it'll tell you the clinical, what other probes you can use, and if you're writing it for your EHR, you would just write your notes, right? So you would do the same. So let's say, for example, home is very supportive. It's a loving home. And the child is, we ask, how are things at school? Again, it's meant to you're supposed to be thinking of it in terms of your own asking the questions, so us telling which specific questions to ask. That's what a mnemonic is. It's a guide, right? And it assumes that you have a little bit of understanding. It can't be just someone who has 0 understanding of mental health or children's mental health. You have to have a basic, a little bit more than basic, but again, it was developed for physicians, and they're already doing a lot of this. right? And we do a lot of this, so I shouldn't have to give you the 13 questions that you ought to ask, but then understanding the general area. So let's say school's going okay, and let's say, but recently they've been, withdrawing from their friends. You ask, has there been any alcohol and drug use? Say occasionally, but not a lot. What about suicide? Have you ever thought of, and if you're not sure, there are sample questions, again, if you have any thoughts about, hurting yourself, or, if you have a plan, and let's just say there's been a bit of ideation, which is like a 1, and feeling a bit down, and the child is currently not on any wait list. So our hospital lawyers make sure that we add this other box, because any tool does not replace clinical judgment, right? And so if you actually submit the questionnaire, it tells you where the score is. And so here, typically the way the cutoffs are based is that a score of 8 on the HEDS-ED or suicidality 2 requires a more significant, you should have a psychiatric or mental health consultation. It could mean the psychiatrist, but if you're an emergency physician and you're in our hospital, or, you'd be able to see our crisis worker, for example, or in the emerge. You can write your discharge instructions, whatever they may be. It will tell you, if in the Cornwall, where to send it, what the resources are, because you identified home as a concern, education as a concern, and what other resources are available in terms of, potential potential concurrent. It lets you print the chart. It lets you print or PDF for the file. It lets you email the results, and for the family, it also lets you, print, for them, so that they can take that, and it shows you what the resources are, and they can go home with that. And I'll show you why that's important in a minute. Back to the PowerPoint. So I'm going to go back to click this thing right here. That work too? Yep. Okay. So I'm going to skip through a couple of these because I've just showed you the. Talked about this. The actual tool itself doesn't require any formal instructions or probing questions. In fact, there is a website you can go to. We have training videos, done by our real, ED physicians, but it doesn't, there isn't any formal instruction. And mostly because if you're going to try to get physicians or other folks that are really busy, and I think even us clinicians sometimes, we think it's just them, but I think it's us as well, that if you have to have training and follow this instruction, that is, you're not going to do it. They just won't have the time. We don't have the time. You add 0, 1, or 2. You determine if the score, if they add up to 8 or above, or suicidality 2, and then it identifies whether or not there's a need for more urgent follow-up in each specific area. So a 2 in any area, you would then say you need care for that. So often you'll find, so the really good example of a 2 is in teens or kids coming, with concurrent disorders, right? And that they may present, family may be very supportive, or there may be a little bit of conflict, school's gone down a little bit, but really the major concern is their substance use. So I walked through those already. I can just flip through those. And the nice thing about the tool was that, again, the web-based, which is a little bit trickier, particularly when you're trying to implement it, because the web-based, what it does is that it helps you link the need to services. And that doesn't necessarily work in an intake office or in an emerge department or in a primary care doc office, because you're dealing with a different EHR, and those EHRs don't necessarily communicate with other websites. So we're trying to figure that out a bit. But essentially, the whole idea is that you want a tool, and remember that the 4th and 5th of those must in terms of tools. It has to improve, the health outcomes, and it has to be services available. So the idea is that if you have a tool that's great for reliability, but doesn't help you direct in care, it's a pretty useless tool. So we have the paper version of the services that are customized in each area. So for example, in our emerge department, what we do is we also have, and for some of the folks in primary care, we have a paper version of those tools, so that if you score this is what you hand out to families. The other little thing that we've done is, again, because I'm not a private entrepreneur and we're not making any money on the tool or the website, is that in part of our other work, which I'll share with you in a minute as well, is the idea is that we give the tool, to the local administrator. So so say for example, East Metro wants to use the tool as part of their stuff. We give them the website. They become the administrator, and then they customize the services based on their area, so that we don't want to be the ones that manage the information. And then similarly, they can choose to either set up their own servers to collect the data, or they can use us, and we'll hold the data. All again, PIPA, FUNG PIPA guidelines. Why is it important to give parents the services, and why is that linkage is important? This is a study that we did in 3 emergency departments. So we looked at the kids coming through CHEO, through IWK, and through Stollery, which is the Children's Hospital in Edmonton. And we looked at almost 400 kids between the ages of 6 to 18. They came in, and this was a prospective study. They came in, we saw them, we did some measurements in terms of their clinical profile. And then we gave them, based on their needs, just a sheet of paper with the services that might be beneficial. And we called them up a month later and found out that 84% of families that got those forms were able to access some services. So, and I think that in some ways that's a real positive thing, that they were able to engage in services and not necessarily have to just rely on an admission to a hospital. And oftentimes people just don't know what's available out there. They just simply don't know. And the percentage that I don't show is how many families, I think there were about roughly 60%, reported being really satisfied with the services that they got as well. So I could tell it's CHEO, right? It's Ottawa. So you're going to deal with Ottawa's a little skewed already. I think that if you take a look at, the evidence, or you take a look at some of the work of kids who come to the Emerge, we do know that certain vulnerable populations are underrepresented. Like, there was a recent publication looking at visits by new Canadians, right? Whether they were refugees or immigrants. And again, you see a disproportionate number of presentations. And so I do think you do get a disproportionate presentation. So these tend to be probably a little bit more. Having said that, I think I would suspect that that knowing where to go is still the most important predictor. So I can go through these because I already showed you in live print. So I'll walk through the psychometric evaluation of the tool. So the first thing I'll do is I'll talk a bit about some of the initial validity and reliability, particularly focus on the concurrent and predictive validity, the inter-rater reliability, sensitivity, and specificity. So this was a study we published in Pediatrics a couple years ago, and we looked at roughly 300 kids who came to our Emerge department. Those kids were all seen by our crisis worker. These are MSW-trained clinicians who have been working there for a while. So pretty experienced folks. In addition to the Heads ED, they also completed John's CANS. And the CANS takes about an hour to complete if you do a nice thorough assessment. The youth completed the Children's Depression Inventory, and roughly 150 of those kids that we saw, the 300, actually ended up being referred for a psychiatric evaluation. So even though it's half of the kids seen by crisis work, you may say, well, that's a lot of kids being seen by psychiatry. In fact, they've already gone through an initial screen that there was a whole bunch of kids that were seen by the ED docs that had already been discharged home. So those 313 represent about a third of the kids that will walk through the door during that time period in our Emerge. And 66 of the kids that actually were, that presented, that had a psychiatric evaluation were admitted. Most places, admission rates in emergency departments is about 10 to 20%, depending where you are. But if you go to certain places, closer to 40%. When I was in the Sioux recently, and doing some of the work there, and they had admission rates over 40%. And I found the same thing when I was in Calgary, where I was at Alberta Children's, and again, overwhelmed with the number of admissions, right? And interestingly enough, a lot of those kids that are coming in, that are being admitted, are kids who have a dual diagnosis. Because again, it speaks to the lack of services available for some of those youth. But anyways, let's leave that for another discussion. These are the correlations between the HEDS-ED scores on those items, on the mnemonic, corresponding with the similar sorts of measures that on the cans. And the first thing you'll notice is that most of the stuff is highly correlated, some a little less than others, but they were all significant, at least 0.01. So in other words, the HEDS-ED scores were similarly correlated on the cans. If you looked at the HEDS-ED score with the youth self-report on their depression, again, whether you're looking at activities, suicidality, or emotions, they were significant. So in other words, the clinicians' ratings on the HEDS-ED were correlated with what the youth reported. If we looked at the reliability between the crisis workers' ratings, and then what we had is a blind RAs go through the charts, just read the notes and try to do the HEDS-ED, and without actually doing the interview, we found, again, interclass correlations that were all highly significant. The last thing is that issue about clinical utility. So this was the interesting piece, because again, based on the score of 8 or greater, or suicidality 2, kids were then seen by the psychiatrist independently of the HEDS-ED score. So they have no idea what the scores were. And in fact, we have sensitivity of 82% and specificity of 87%. And those are pretty good specificity and sensitivity for the work that we do. So those were the crisis workers. But what about the ED physicians, right? So how did they do in terms of their validation, right? So this was a study that we, again, just published recently, and we included in that study roughly 650 kids over the age of 12, so they were a bit older, right? Again, representing, those are the vast majority of kids who come to the Emerge. And what we did was we took the tool, all we did, because again, I could tell you that, we've been working really hard in terms of some of the training stuff that we're trying to do with other hospitals in terms of their emergency departments. You cannot find the time, and the ED docs just do not have the time to come in for training. It'll never happen. But it's the same thing if you're dealing with community pediatricians or family doctors or FITs or FOs or whatever. You'll get a room full of folks, and there'll be 2 physicians, and the rest are the support staff. We took the tool. All we did was stapled it to the back then we still hadn't moved to Epic. So we just stapled it to the chart. That was it. And so before they saw the youth, they'd have the tool, available. That's all we did. And again, about 40% of those kids were referred by the ED physician to the crisis workers. So we have who also did the HEDS-ED, who do their normal kind of assessment. For us at CHEO now, the HEDS-ED is part of normal clinical care. Here's what we found. Again, remember, no training, right? That's all they had was the staple tool. That the physician's mean HEDS-ED score was significantly higher for those that they referred on for a consultation compared to those that they did not. And it was significantly higher for those kids that were admitted to hospital, those that were discharged. So they rated in a way that we hoped they would. Here's the other interesting one. This is the interclass correlations between the physician's ratings with 0 training with the crisis workers, okay, who don't know who didn't see what the physicians had done, right? And you can see that they were all correlated. So the physician and the crisis workers essentially landed at the same place when they were rating the various domains in the HEDS-ED. Now, some was a bit less, not quite as highly correlated, and that's mostly because we weren't surprised to hear that, because if you're spending an hour doing an interview versus 10 minutes, you are going to be able to really get it a little bit differently. But the other part too is that the crisis worker is also trying to get the child out of the Emerge, right? So the ED doc sees them and says, wow, this child may be a 1 or 2, right? Needs immediate assistance. By the time the crisis worker is finished, they're a 1, right? So we can, get them out of the Emerge and into the community, and engaging services more commensurate with their need. Having said that, they're still really highly correlated. And again, the tool doesn't replace clinical judgments, but if you look at the overall scores on the tool, the gray meaning consultation, the dark meaning admission. So the kids who scored higher in the tool were more likely to have a consultation. The kids who scored even higher were tended to be admitted. But not everyone, because sometimes you have to get that additional service even though they may not score that high. You got to use some clinical judgment. We did take a look at those, you know, and again, going back to the clinical utility and our sensitivity, there were some kids that tested positive and they didn't get consultations, and we're pretty worried about those kids. If you're scoring, you know, a suicidal and you're not seeing anyone, like, why is that? So we pulled their health records. There were 12 that have potential high-risk scares. In fact, 6 patients had urgent follow-up scheduled in the next couple of days, so that was part of the reason why they never bothered with the consultation. They felt safe enough to go home. 2 were accidentally or incorrectly scored on suicidality. Really, they're presenting with non-suicidal self-harm. And 4 had no discharge recommendations on the chart. So we didn't know what actually happened. We could only hope that it was just poor charting. And in fact, we have another study that we published years ago that showed how poorly we do our charting. So that's what we're attributing to. I just can't imagine there are physicians or would have discharged the youth without some sort of consultation or some plan. I'm not sure, Norman, if you saw this, if you heard about this publication. This is just, okay, so it's just been accepted. It will be in print in hospital pediatrics. And the reason I'm asking Norman, because when we were doing work on the HEADS ED with Sharon, who actually approached us at IWK, she's a psychologist there, who was helping with the CAPA program and in terms of, you know, developing a better centralized intake in terms of helping to guide decisions, had asked us about the tool and whether or not we felt it could be used for an intake. And we said, well, give it a shot, right? And this is the data on one of their studies that was just accepted for publication in hospital pediatrics, and I'll share with you, with her permission, and now that it's going to be in print, what we found. So essentially, when Sharon was looking at, you know, a tool, they wanted to find something that had some evidence, you know, to support it. And there was a little bit of evidence on the HEADS ED, at least in the eMERGE, that it would help to facilitate patients and families to direct towards the next step of care, and that is clearly what it was that we were trying to develop, and that it would also be helpful for the next person having to, you know, take care of that child or youth or family, right? So again, it should help not just the family, but also help the provider. So this is a study that looked at the kids that went through their centralized intake. So IWK is the is the tertiary hospital in Nova Scotia and in the region, I guess, right? And any child, you know, there are lots of kids that are referred, you know, for specialized programs, and they would go through the centralized intake. The first thing I want to show you is that there were 60 kids under the age of 5 that also actually had that first tool, right? But the vast majority, again, were between ages 6 to 12 or a bit older. And the interesting thing is, if you take a look at the scores, these are the mean scores. The older the kids, you know, they're presenting with more challenges in terms of those ratings than the younger kids, right? And I think it may not necessarily be that the younger kids aren't presenting with significant, you know, concerns, but they're not presenting with the concerns that are identified on that mnemonic, right? You know, we kind of makes sense. But here's the interesting piece. The interesting piece is that if you take a look at the scores on the HEADS ED based on the level of care that they needed, so these are the kids that score of 2.62, the mean score, the kids that they felt didn't need services provided at IWK, didn't meet kind of their cutoff for specialized care. So they were much lower than the kids that were accepted into different types of care at the hospital. So the Strongest Family, which is a parenting program, I'm sure you folks are familiar with the Strongest Family, you know, they had a mean score of 3.5, whereas the kids along the continuum who require more specialized care, to those who had a priority appointment. Priority appointments are the kids that need to be seen immediately or really, really quickly because of their level of need, scored the highest, in addition to those kids coming in with both mental health and concurrent disorders. So it worked in a way that made good clinical sense, right? And it helped to guide their decisions in terms of the treatment. And in fact, the next note. And there's a slide that basically, not including this presentation, where we looked at the kids who, if they went to Strongest Family, for example, did Strongest Family actually feel that that was a good fit? Versus, why are you sending them here? They really need, you know, outpatient care. They need a priority appointment. And so, in fact, a concordance between the services that they got versus and the acceptance of the service was, I think, there were only a few times where it was where there was a mismatch. So it was, they landed where they ought to land. The other thing is that we looked at the correlations between the intake navigators. There were 5 navigators at IWK, And we pulled the files, and they had research assistants take a look at those ratings independently of what the navigators found. And again, they were either significant or approaching significance. The one here was the emotions, behaviors, and thoughts. And this is where we added, when they were originally doing the validation, was based on the, needs immediate, support right away or can wait, right? And versus the idea that you should be also assessing functional impairment. So the concern was that the navigators were reluctant to use a 2 rating, even though they required immediate services. So they would end up being rated as a 1, just need services, but not immediately, because they were really reluctant to put a 2. And that's now been changed. And I think if we went back and we redid the reliability based on the new anchors, I think we'd see even increasing.
Just my overall impression with that, because I looked at, just anecdotally, I've looked at some of these, and for the younger age group, it'll be more like a 2 in one area rather than overall. And,
so they get, it's like home is, So and again, it's the idea that Norm was saying, like what ends up happening on the heads ED for the under 6 is that they get a rating of 2, for example, on one of those. It could be 2 on home and a 2 on emotions and behavior, but you're not going to get things on suicidality. Right? At least you certainly hope not, right? So, drugs and alcohol and So, and again, it kind of, and the ratings that tended to be the highest are those kids coming in with the concurrent disorders, which there's problems at home, there's problems with their peers, there's problems with drugs and alcohol, there's problems at school, there's problems with behavior. So they are going to ultimately score much, much higher. Okay, no questions to the end. No, I'm only kidding. I think it's. I thought you were going to ask a question.
No, I'm sorry. I was just going to pass.
Oh, okay, great. No. Oh, we got a question. First of all, it's really nice to have questions.
It's for the people online.
Yeah.
Okay.
If you can identify yourself.
Just out of curiosity.
Yep, sure.
My name is Sandy.
Hi, Sandy.
And out of curiosity, if they score a 2 on the family piece.
Okay.
So what happens in terms of the referral process with that piece? If it indicates that is a determining factor on how that individual is functioning.
So at IWK, there'd be 1 or 2 things, and Norm, you're here if you can help me out if I guess wrong, but there's 1 or 2 things that could happen. That it would either be triaged to strongest family. So typically the kids are presenting with challenges at home, and almost always there's going to be behavioral issues. Or 2, if they had other concerns, let's imagine that there was a worry about a spectrum disorder, developmental, disability, then they would be triaged to what would, in part of their intake system, would be what we call a regular appointment, where they then would have a more in-depth assessment to better identify the level of care, right?
that's where the role of the navigators is very, very important, because they actually work with the families, and at another level, we administer the SDQ, the Strengths and Difficulties Questionnaire, to kind of like have a more in-depth assessment, and that's done with the navigator as well. So navigators are really, really important.
So getting the news out, like letting people know, what it is. Maybe if we were entrepreneurial and we were actually trying to make a buck, we would be out there, doing a better job of marketing the tool. But, we also know that if you do that, then no one's going to use the tool, right? And so, but people have heard about it. It's being used in hospital EDs and hospital clinics. It's been used in community mental health as part of their intake and in primary care. And I'll just touch a bit. At CHEO, for example, the HEADS ED is part of our EPIC. Any child or youth being referred to our centralized intake, they also do a HEADS ED. But again, it's part of our health record now, which is great. So therefore, it's responsive at a local level. This is my daughter's high school. This is Immaculata High School. And you'll notice this is a frozen canal. So all you folks in Toronto who say, man, we really want to experience the winter, because you don't get it here really, or in Niagara, come to Ottawa during Winterlude, and you can skate on the canal, and you can say, oh, that's Mariel's daughter's high school. It used to be a college, by the way, at one time. But the point is that the heads ED now is used by our school boards, our mental health leads. So this is where the community piece comes into it, right? So they actually, we have a pager in the Emerge with our crisis worker. So before the child comes to the Emerge, we have a protocol that we follow. So we already, for those kids that need to be there, we're expecting their arrival. We already have a bit of a clinical background. So when the crisis worker then in the Emerge sees them, they don't have to see the ED doc. It just helps the family, you know, in terms of getting the services that they need. And it helps, you know, and it helps the mental health leads and the folks in the schools, you know, with their, you know, triaging, you know, to care. The other thing too is also supports the school in terms of saying, look, no point bringing you to CHEO. You know, they're not going to, you know, this isn't the place for you. Let's try to find some place for you. And we'll actually try to help navigate some of that with them, because not everyone knows all the services available at Gain, right? So the idea that the responsiveness at a hospital, at a community level. At a societal level, the heads ED, there was, this is the Provincial Council for Maternal and Child Health a few years ago, had a, you know, did a pathway for kids coming to the Emerge that for the province of Ontario. The heads ED is part of that ED clinical pathway. It's been implemented in different places. I know it's had some work in the Toronto region. It's currently being implemented in the Ottawa area with the CHEO and some of the community hospitals, some of our rural hospitals. And it's just, we published the pathway in the child and adolescent psychiatric clinics in North America so that they're also familiar with the work that we're doing in the pathway. So again, the idea that it doesn't matter where your child is, you know, the tools and the pathways should make sense and help get kids the care they need. This is the how the tool has now expanded its use to the community. So this is part of the work done in Toronto in terms of its centralized intake. And so the heads ED is part of the triage, you know, instruments. So when kids are referred, that they would help, you know, in terms of their disposition. We're doing some work in primary care. You know, try to tell these young folks that, you know, your iPhone is not a navigator. And again, I'm not going to go through this, but you know, primary care physicians face the same challenges as our emergency docs, right? They see a lot of kids. They're you know, they don't have a lot of time. They haven't had a lot of training. And they all recognize that they want to do a better job at it. And they're not really comfortable with what they're doing. And so the idea was, can the tool also help primary care folks in terms of their being, you know, their assessment and triaging of care. So what we did is we took a step back. Stephanie Leon was my PhD student who's now graduated and is working at CHEO as a neuropsychologist. And we wrote this policy paper called Paving the Path to Connected Care. There are 2 policy papers out there for under the age of 6 with the Center of Excellence. One is already published. And one is close to being published, right, John? I hope so, yeah. So this one here looked at, we wanted to take a step back and try to see, look at the evidence out there in terms of connecting primary care with community-based mental health services. And this is what's really important for us, right? Do the docs know what's out there, and how do we help, you know, how do we help those physicians connect, you know, or those providers connect with our community base, right? And oftentimes when we think about, you know, collaborative care, we think about, you know, the social worker or the psychologist or the child and youth worker working within, you know, that family health team. But that's not the way it really works, right? The way it really works is that, you know, they just don't know what's available and they're trying to scramble for services. And it's always a referral of, oh, I know Norman, I'm just going to send it to Norm and he can, you know, deal with this, right? And not understanding there's a real range of services, John.
I just want to put a bit of context around that for the 0 to 6 and in particular the 0 to 3, because we've run a number of what we call community tables where we're in communities documenting what they're doing. And the challenge here is that physicians really don't Like they're not thinking mental health at all.
Yeah.
And they're not thinking about all the things that contribute to that young child's mental health. So physicians are routinely at our community tables, and there are people in the room who have participated and people online who have participated in those tables. Physicians are actually a very significant barrier to service because they say to parents, it's not a worry, it's not a concern. So parents feel very dismissed.
Right.
So I think that has to inform, you know, as you work on this tool, that experience, given that it's being developed first for primary care, is my understanding.
Yeah.
How do you deal with that?
So we find, you know, and I think, and just, you know, that way of thinking is in some ways, you know, not just for 0 to 6, right? You'll find it, you know, and I think it's, you know, it's kind of like particularly more, you know, obvious in the 0 to 6. You know, we know that, right? And you know, but you also see it also. Like, they don't ask about suicidality because, you know, then what am I going to do, right? They don't ask about drug use because then what am I going to do, right? They don't ask about, you know, addiction to, you know, gaming or addiction to pornography because then what am I going to do, right? So I think they just don't ask, right? But I also think that they need to have, this is the whole idea behind something like the HEADS ED, right? It's the idea that you can ask, but we're also going to help you identify the services. And we don't have navigators out there, navigators out in the community that you can access. 211 isn't going to do it, and they won't use those sorts of things, right? So we want to, you know, it's kind of that linkage. So let me just quickly go through the one thing about, just mindful of time. The one thing about these policy papers, right, and I've been involved in a few of them now, is that they're great for the writers, right? We feel really good about ourselves. We get this, you know, we get this great publication out there. We have this policy paper, and, you know, we put it on our CVs, but like they just collect dust, right? At the end of the day, you know, you hope that someone reads it. You know, people work really hard, and but what I really pushed the center this time is to say, can we take this policy paper, when I want to push, you know, folks to try, and part of the reason why we're here too is that push them to say, if you're going to take the time to, you know, write these papers, you know, can we actually take a look at some of those recommendations and see whether we can do something about it? So just, you know, let's not make it just collect dust. So we took ours. There were 8 recommendations. We looked at 3 recommendations in terms of running a pilot. So. And we ran it on 2 sites. We ran it here in Toronto, East Metro. And then the other site that we did, you know, some of the pilot work was our folks in Algoma, which is really, you know, again, the folks up north. It's a, you know, they have other, you know, there's other concerns there. You know, there again, even less services. They have First Nations and, you know, populations up there. And people ask me, why'd you pick, you know, Algoma? Why not, I don't know, Belleville or somewhere else? And I said, well, you know, this is the one perk you do have, is that if I have to do this, I'm going to at least do it at a place I want to do it, and I'm from the Sioux. So if I have to travel, I'm also go see my family while I'm out there doing the work. But again, you know, Algoma Family Services is not an unusual, or it's a very typical exemplar for other similar sorts of communities. We started working on it in 2017. We just finished in 2018. We did a primary care forum here in Toronto where we presented the results. And these are the pathways. And I know you can't really read them. I realize that. But essentially, you know, when people think pathways, they think really complicated, right? And I'm not sure if you've gotten it by now, but I try to make things really, really simple, because if you make anything complicated, it ain't going to be done, right? And if you look at clinical pathways, you know, you need a PhD just to figure out what to do, right? So these pathways are really simple. Child comes in to see the primary care doc. The primary care doc gives them the HEADS ED. If they score 8 or score 2, they send them to the emerge. If they score under 8 or not 2, they then send them to the community. We list it. These are the services available in East Metro where we were doing the pilot. These are the services available in Algoma where we were doing the pilot. And then the folks in the community would get back to the primary care doc and say, we're going to be following this youth. May not, you know, they may say, we got the referral. It's going to be a couple months before we see the youth, but we got the referral. And this is an important thing for people in primary care, right? They need to know that when they're referring to you folks, that loop closes, right? And it's a real, they see it as that black box. So we hear it all the time. I send them out, I don't hear anything back. So that closing the loop, right? And we know that there's reasons why. There's arguments in terms of consent, other things, and what constitutes a circle of care. And I always say, well, maybe that's going to be different now that we're all under health and no longer under, child and youth. So we'll see. We did an evaluation with some key informant interviews, and basically we got some feedback from folks. And everything we do is very evidence-based. We use this thing called the theoretical domains framework, which guided our questions in our path. And one of the things that came up, for example, was knowledge. People were saying, we know that you don't need a lot of training, but can you please give us some training, right? So I think we all want some training. So we have some webinars and things like that. But the other piece is that last piece, right? Which is the idea that, again, that it's nice, it'd be really good if they all understood the same, we're able to communicate the same language. So a two is a two, regardless if you're a family physician or a community core service provider. So just to share the work we are doing, we're going to be moving forward with 6 more sites where we're looking at the HEDS-ED and the clinical pathways. We're going to be in Toronto and Algoma, and there's 4 other sites and potentially 5 other sites. We confirmed those, but they haven't been publicly announced. But we'll be moving this forward in the new year. And basically the question is, it's kind of a question that we probably want to ask ourselves, regardless of age. How effective is a primary care pathway in helping children, youth, and families access community-based mental health services in a timely and appropriate manner? That's what we really want to ask ourselves. The last thing about the HEDS-ED before I move on is that we published it as a Creative Commons. So there was no strings attached to it. So the good news is anyone can use it. The bad news is we don't know who's using it. We get emails often, almost monthly, folks asking us, we're interested, we saw your tool, we've heard about your tool, how do we use your tool? Would you let us use your tool? And just to give you an example, we just got off the phone with the folks at Yale, so they're going to be using it, Yale will be using it in New York as part of their in their School of Medicine, and in the Yale New Haven Hospital, which is a huge hospital for kids who come to their emerge. So these the HEDS-ED in the pathway.
Is it 6 to whatever 18, or is it 0 to?
No, the one that published by Sharon is 0 and up.
Yeah, but the one you're planning for, you're gonna have sites.
Ideally, I like to include the full range, and that's part of the reason why I'm also here, right? And I think part of the validation piece, right? This is the opportunity. This is where we can sort of think about, customizing the tool for the 0 to 6, and I can then include it as part of the validation. I got a call the other day from East Metro asking me, where are things at with your 0 to 6, Mario? Because the initial conversation was in November 2017, and sure enough, someone's ears were ringing, thinking, where are you at, right? And I said, odd that you should ask. They go, I will actually be here today, right? So this is the 0 to 6, and I'm just going to go to the website only because it's just easier to look at. So way back, we just did a quick little HEDS-ED for the 0 to 6 kids, and I'm just going to sort of show you. I think everyone got the paper version of it, right? And I think I gave the link, but imagine you have like a
quick question about the former version that you were talking about. Is there a particular score or pattern of scores that would indicate that a referral to child welfare would be appropriate?
Again, it's not necessarily the score itself, right? But part of it is that clinical interview that's being done, right? So the idea is that if let's just say, for example, home is chaotic and there are concerns, then that could be the link, to the call to for child protection. Yeah.
So our crisis workers at our hospital would automatically go in and see home environment. And then they would probably.
Okay, so but is that related to a score on a particular?
No,
Not an overall.
Yeah, we haven't looked at, no, I know, have we actually looked at the correlation between referrals to child protection and score? We haven't. So
Okay.
that's, yeah.
This is just.
Okay. So a community-metric was designed for each item to be able to stand on its own. So it's not like a typical psychometric measure where you want to look at the internal consistency. They all hang together for one construct. We wouldn't expect them necessarily to be all correlated together. So each item in and of itself can be, so I have a 2, is there action I need to take based on the home?
Yeah.
So the total score is an indication of total overall level of need, but each item on itself can lead to different outcomes in terms of where, say, the Access Navigator and IWK, they have written within their kind of questions, if someone scores this, then don't send them here, make sure they go down this path. So it can be tailored a little bit that way, depending on your site and what the needs are. Yes.
That's right.
Yes. Yes.
I only have about 5 minutes left, and then we could, I thought, then we could, we'll have a break and then go to the second part, which is the part that I'm most interested in. So this is the U6 version of it, just to sort of walk you through the website, which we had a mock of. So imagine it was gender was English and it was male, and let's just say there is no suspected autism or developmental disability. Typically, what we've done is that on the older one is that if a child has a suspected or confirmed spectrum of developmental disability, it's pointless to give the parents a list of services that it doesn't make sense. It just automatically goes to that page, right? So you can see how now that it's not just home, it's also about caregivers, right? And 0 would be that the home is supportive or responsive to child's needs, and there's a good sense of secure attachment. 1 is that there's conflict, there's some difficulty meeting needs, and that there are some attachment concerns. And 2, meaning that this is chaotic, they can't meet the child's needs. There's a placement breakdown, and there's some severe attachment disorders. E goes from it goes from eating, it stays as eating and sleeping, right? Again, no concerns to sleep deprived and failure to thrive. Activities and peers is the same mnemonic, where it's age appropriate social skills and engaged in activities, restricted range or interest in social activities, limited social skills and limited friendships, withdrawal or extremely restricted range of activities, unable to function in a societal context. B is a catch-all for development, both speech, language, and motor, in terms of appropriate, some deficits, profound deficits in any of those. S goes from suicidality to safety, right? It's like, how safe is the home, where there's no concerns, or there's some level of risk, and there's some impulsive behavior, and there's some that could lead to some severe health issues, or there's imminent risk, requires some immediate attention. Child comes in with a broken arm, right? And there's a threatening and impulsive behavior on the child. So the child is so out of control that, from a child's perspective, that it's high risk. Emotions and behavior stays essentially the same, except for now we're a little bit more focused on, aggressivity and out of control behavior, and discharge and current resources stays the same. There's a reason why, imagine you're in a primary care doc's office and you have a 4-year-old. So the thing about using the same mnemonic is that everyone uses it, it'll be easier for them to remember, right? It's easy, right? It's got to be easy, right? But the other thing too is it lets us, if they put an age of 4, then you're using the head ZD for the 4 versus the head ZD for the 8-year-old. And what really changes are those mnemonics and the domains and the level of action needed within each of those. And so if we actually, there are some sample questions that you could have asked, and then just to sort of go through, I think I'm just putting these down. As you can see, we give a score, but there's nothing, there's no paragraph after the score, because we don't know what a 6 means. Well, what's a 6, right? We know what it means for the other one. We have no idea what a 6 would mean for this, if that's where we want to land, right? And again, we would do the same sort of thing in terms of being able to print or PDF or email to give resources and so on. So just to go back to the slides and to finish up. So we really want to now look at, what do I think we should look at, and what do you guys think we should look at, and how do we move forward on this? So the first thing is, how do we look at concurrent and predictive validity? Should we be looking at something like the HEDCD along with the Ontario's enhanced 18th month well baby visit? We're currently working with the academic family health team in Ottawa, and Farhad Motamedi is he's the unit director there, and he's on, he and I and Paula are looking at the tool in primary care. And we originally were going to look at the kids over the age of 6, and then we said, wait a second, we're developing this. This is, why can't we start younger? Which basically caused about an 8-month delay in REB. But we finally got REB approval. When was that, Paula? Last week. So, and for our chart review. So we're going to be looking at all children and youth 10 months to 25 years. We're going to look at between September 1st and December 31st, 28. And our goal is to try to look at what the number of children and youth seen with mental health concerns, determine the current practice in regards to patient treatment, follow-up, and recommendations, and determine patients' mental health needs using the HEDCD as a tool. So we'll look at if those are the kind of mnemonics that we think when we do the chart review, we'll use those mnemonics to look at the data to say, does it make sense, looking at what they did in terms of the enhanced 18th month, and also if there's any other data in their chart that we can use to extract their needs. It's a fit, I know. And so, other things we thought about, is, could we be looking at, forgetting about the fit, but, could we be doing studies looking at the correlation between the HEDCD and the Nipissing, or the ages and stages questionnaires, or the parenting stress index, and are there other ones, and how should we do it? Should we, could we ask clinics to say, would you be interested in working on a validation with us? And when you're doing the measures that you're currently using, would you mind also doing the HEDCD? And then we'll look at the data and we can see what the correlations are. Some people already using the, maybe already using the, the ask, right? And so it would just be really easy to do that. Questions that we need to think about is, at what age do we do it? Do we do it at like 1 year, 18th month, 24 months, 36, or do we kind of just start, we pick a couple dates, right? We say these are the ones we want to look at. And how do we make sure that we also capture vulnerable or other specific populations and not just, a subpopulation of high functioning, families? In terms of inter-rater reliability, there's different ways of doing it. Again, we could do it through chart reviews or vignette based with multiple raters, or we can do actual recordings. The vignette based are interesting because that's how you often get your certification on the tools. So I'll give you an example. This is what we've done is, this is an example of a vignette. So Paige is a 14-year-old female who's brought to the Emerge by ambulance after seriously cutting her wrist with a kitchen knife. The cuts on her wrists were deep. A mom called 911. She's been talking about wanting to die and be with a famous singer who died from a drug overdose, and she was hospitalized and so on. She lives with her mother and so on. Paige has difficulty in school for the past 2 months, has had several friends, and she says she doesn't enjoy what they do anymore, so she's spending less time in class. So this is a vignette of a typical, this is not a, this is like a typical kid that we get in the Emerge who presents with suicidal risk, right? And so if you actually looked at that vignette, we could tease out, the suicidal risks, the home stuff, peers and activities. So the question is, can we develop some vignettes for 0 to 6? What is a typical, 4-year-old presenting with a mom? Go ahead, sorry.
I'm wondering for the 0 to 6, especially in the birth to 3, right, where the caregiver is so significantly important in that relationship, right? If you considered actually pairing up the HEDCD adult version with the HEDCD younger version, because I wonder if it might be important for clinicians to get a sense of where their caregiver is at and what risk factors might be available to them, and then how those might impact the relationship or the infant or their perception or what have you.
So I think there's a couple things, and I think that's a really good question. The question is, is there a way of looking at, how well the parent is functioning, and then looking at the correlation between the parent's functioning and the child's functioning. So the HEDS-ED really caps out at about the age of 25. And we've actually been asked, can you, is there a way of developing a HEDS-ED that might be more sensitive to adults, right? And maybe tease into some of that. I think that's where I draw the line. And because I've been asked a couple of times, I go, I'm not going to the adult world. I don't, I'm done, So, and that's why I thought of, I'm not sure if it's like something like the parenting stress index or other things that lets us get a sense of functioning, because I think that's part of the correlation, right? I think, the whole idea is that if the HEDS-ED score in 0 to 6 is elevated and the parents aren't doing well and they're elevated, they should be leading you to a certain pathway compared to, a different pathway, right? And, but, again, we haven't, that's what I'm really hoping that we spend the next hour talking a bit about. But I think the vignettes is interesting because the vignettes is a good way of capturing, some exemplars of the different kids that you might see in your practice. Say, like, this is the way this child looks like. This is the way we get the kids that come in who do present with severe attachment. These are the kids that do come in with trauma, with parents aren't functioning, right? And then do we all rate this tool the same way? So we actually have some on, we have one on that. We have another vignette for a typical child who presents with a concurrent disorder, again, and then one that presents with anxiety. So we get lots of kids who come into the emerge, little kids with panic attacks and clearly OCD, right? And because we always think emerge is, suicide, but that's not the case. About a third of those kids. So we have a vignette for a child presenting to the emerge with, or with primary care for that matter of fact, because we're doing the same thing with anxiety. Talked a little bit about the interrater reliability strategy. So again, we can do chart reviews, or we can do the audio recordings. And again, these become a little more expensive or resource intensive. So I tried to make sure that I wrapped up within about an hour and a bit. I went a little more than I would like to have, but I really want to spend, if I can, the next hour or so thinking about what the tool, the actual tool itself, do the mnemonics make sense? Do those kind of categories make sense? What would you suggest in terms of scrapping, or what do you think we should kind of be, modifying a bit? Think about those validity strategies. Is there a way of doing some of that validity work, with, some of the folks here? And, do we have a bit of a timeline to be able to do that? I know the folks, like I said, the folks with Mental Health Toronto are going to be using, I'd like to include the tool, for that population. We're going to be using it in Ottawa to validate with our academic family health team. But what I'm really missing at the end of the day is, if we're going to validate it, it has to make sense to the folks who actually work with these kids, and not just us in terms of test developers. So, thank you.